Good afternoon, everybody. My name is Tatiana Diaz. My topic is right atrium. Definition: the right upper chamber of the heart. The right atrium received oxygenated blood from the body through the vena cava and pumped into the right ventricle, which then sent it to the lungs to be oxygenated.
Okay, so in this tutorial we're going to look at some of the features of the right side of the heart. And we'll start off with the atrium, and we'll look at some of the external and internal features, and then we'll look at the right ventricle and look at some of the features internally and externally. So we'll start off by looking at the right side of the heart. So I'm assuming a bit of preliminary knowledge, so you know the basic structure of the heart in terms of the atria and ventricles, and also that you are aware of the great vessels and what these are, and sort of the basic function of the heart. So the right side of the heart receives deoxygenated blood, and it receives this blood from two great vessels. So you've got the superior vena cava and the inferior vena cava, and then you've got the coronary sinus at the back, which delivers deoxygenated blood from the walls of the heart into the right atrium. So the right atrium contracts and sends blood into the right ventricle through the right atrioventricular orifice. So what I've done here is I've just sliced a little bit of the right side of the heart away, and we can take a look inside the heart. So you can see this opening here. So this is the right atrioventricular orifice, which opens up from the atrium into the ventricle. And this is closed by the tricuspid valve when the right ventricle contracts. So the way of remembering, so you should know the basic makeup of the heart. You've got the atrioventricular valves and you've got the semilunar valves. So the atrioventricular valves, you've got the tricuspid valve on the right, and you've got the mitral valve or bicuspid valve on the left. So the way to remember that the tricuspid valve is on the right is that tri has RI in the name, so it's on the right, whereas mitral doesn't have this. So tri-right, so it's the right atrioventricular valve, and this closes when the right ventricle contracts. So that's the right atrioventricular orifice opening into the right ventricle. So within the right atrium you've essentially got two spaces, and they're divided by something called the sulcus terminalis on the external surface of the heart, and internally this corresponds to the crista terminalis. So these structures separate the smooth posterior wall from the ridged muscular anterior wall. So you've got these two spaces within the right atrium. So just taking a look at the right atrium externally, you've got this notable little appendage here. This is the right atrial appendage, or the right auricle, and this little conical pouch overlaps the ascending aorta, and I'll come on to mention that in a bit.
Application in medicine. The central role is one on the application in medicine, because strong it is giving strong medication, large amount electrolytes, etc.
The needle is held at a 45-degree angle to the skin and is advanced toward the ipsilateral nipple. For the central approach, establish the location of the sternal and clavicular bellies of the sternocleidomastoid. Needle entry occurs in the superior apex of the triangle formed by these muscles. The needle is held at a 45 to 60-degree angle to the skin and is advanced toward the ipsilateral nipple. The needle is held at a 30 to 45-degree angle to the skin and is directed toward the sternal notch. Position the patient supine with the stretcher placed in 15 to 30 degrees of Trendelenburg. The bed should be at sufficient height so that you do not have to bend over or stretch during the procedure. You may encounter some resistance during dilator advancement. A slight rotating motion may be helpful. You may now remove the dilator, leaving the guide wire in the vessel. Next, advance the triple lumen catheter over the guide wire. You must grasp the wire from the distal end hub before fully advancing the catheter into the vessel. Once the catheter has been placed, remove the guide wire and immediately cover the hub with your finger. Finally, place an end cap onto the open hub and flush all of the ports with saline. Secure the line in place with a stitch and place a sterile dressing over the line in accordance with local institutional policies. A chest radiograph should be obtained after all internal jugular line insertions to assess for proper positioning of the catheter tip in the superior vena cava and to evaluate for iatrogenic pneumothorax.
Advantage. Psychologically, the right atrium takes great importance until landmark, its central venous pressure, which indicates the state of the circulatory system. The right atrium resides blood that comes from the hadal vein, cava superior and inferior. Disadvantage. Moderate valvular disease may be asymptomatic. It is a bad disadvantage to not being able to gain male treatment. The disorder can be identified only if the doctor, with a stethoscope auscultation,
to improve your ability to hear S3, S4, and the murmur of mitral stenosis, have the patient roll partway onto his left side, which brings the left ventricle closer to the chest wall. Then recheck the position of the apical impulse and place the bell lightly on it. If the patient had an audible S3, it would sound like this. Notice how the third heart sound disappears when the bell is placed more firmly on the chest wall. Listen again with light pressure. With firm pressure. And once again with light pressure. To help detect aortic murmurs, especially that of aortic regurgitation, have the patient sit up and lean forward. Then ask him to exhale completely and hold his breath out. Using the diaphragm of the stethoscope, listen at the left second interspace and down the left sternal border to the apex.
Breathe out completely again and hold it.
Pause periodically to allow the patient to breathe. Listen for the high-pitched diastolic murmur of aortic regurgitation. If the patient had this murmur, it would sound like this.
You may breathe. Take another deep breath. Breathe out and hold it.
Heart murmurs can be distinguished from heart sounds by their longer duration. Diastolic murmurs, like this one, usually indicate heart disease. Systolic murmurs can occur in healthy people or in those with heart disease. For example, a loud mid-systolic murmur may be heard in aortic stenosis. such a loud murmur, palpate the area with the ball of your hand. Palpable vibrations associated with a heart murmur are called a thrill.
Disadvantage: atrial fibrillation, stenosis, hypertrophy, regulation.
In AFib, the top two chambers of the heart, or atria, beat very fast and in an irregular pattern that is out of rhythm. Notice how the atria appear to quiver and are uncoordinated. Due to this irregular pattern, the atria do not coordinate with the ventricles, and the heart is out of rhythm. AFib occurs when electrical signals start in the wrong place and misfire. The faulty signals cause the atria to quiver and not contract completely. Notice how the signals spread in a rapid, disorganized way. Your doctor may perform a test called an electrocardiogram, or an EKG, to see your heart's electrical activity and rhythm. During an EKG, small electrodes are placed on specific parts of your arms, chest, and legs using small stickers. When the heart beats, the electrodes send signals to the EKG machine. The EKG measures the electrical impulses or waves shown here as lines. See the differences between a healthy heart and a heart in AFib? In a normal heart, beats are evenly spaced and show a regular pattern. In AFib, the waves appear more chaotic and random. While the causes of AFib are often unknown, there are a number of things that increase the chances you might get it. Some of these include age, family history, smoking, high blood pressure, or hypertension and obesity. Also, if you have any of the following conditions, you're more at risk of AFib: heart failure, diabetes, or coronary artery disease. The more of these risk factors you have, the more likely it is you might experience AFib. Be sure to discuss your full medical history with your healthcare provider.
Hypertrophy.
Enlargement of the right atrium is seen as an enlargement of the right heart border bulging to the right of the spine. It is usually associated with right ventricular enlargement also. In this X-ray of cardiomegaly, note the enlargement of the right heart border to the right of the spine, indicating dilatation of the right atrium. This is right atrial hypertrophy.
Thank you, everybody.